Good morning, everyone. My name is Alison Hoons, and I'm a knowledge broker and a member of the Patient Advisory Board at Arthritis Research Canada. Before we begin today's session, we'd like to respectfully acknowledge that Arthritis Research Canada's headquarters are located on the stolen traditional territories of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. We express our deep gratitude to the keepers of these lands and waters. I'm thrilled to be your moderator for today's webinar, and I'm excited to learn from our expert, Dr. Alyssa Howren. Our patient expert for this episode is Bableen Parmar, who's a member of Arthritis Research Canada's Patient Advisory Board. If you're joining us for the first time, this webinar is part of Arthritis Research Education Series, which was created by Arthritis Patient Advisory Board to share research undertaken at Arthritis Research Canada. Dr. Howren will give a short presentation and will then be joined by Bableen for a Q&A session. Please click on the Q&A icon on the lower right-hand corner of your screen to type your questions. We also invite you to stay on at the end of the webinar to watch the 5-minute video that was prepared for this episode. Now a little bit about Alyssa Howren. Dr. Alyssa Howren is a postdoctoral fellow at Stanford University's Department of Epidemiology and Population Health in the School of Medicine. She completed her master's degree and her PhD training here in the University of British Columbia's Faculty of Pharmaceutical Sciences. During this time, she was also a trainee at Arthritis Research Canada. Her research focuses on the complex relationship between depression, anxiety, and inflammatory arthritis. She's also done research to understand how people living with inflammatory arthritis and mental health disorders receive medical treatment. Her postdoctoral research at Stanford will evaluate how family doctors make treatment decisions for several chronic diseases, including lupus and depression. So welcome, Dr. Howren.
Hi, thank you, Allison. I'll just start sharing my slides with everyone. There we go. So thank you so much for having me here today. I'm really happy to be presenting on this topic as arthritis has been a focus of my work. For the past 10 years. And I've been particularly interested in understanding the relationship between arthritis and mental health. Before I begin, I just wanted to acknowledge that I'm joining from Menlo Park, California, which is situated on the traditional, ancestral, and unceded territory of the Ohlone people. We recognize their lasting connection to this land and honor their cultural heritage, history, and contributions. As we gather here, we commit to understanding the impacts of colonization and working towards justice and reconciliation with Indigenous communities. So for today's webinar, I'll be focusing on the difference between mental health and mental health disorders, the connection between arthritis and mental health, and then how mental health experiences can differ between men and women. So across Canada, approximately 6 million Canadians are affected by arthritis. When we consider the occurrence of mental health disorders such as depression and anxiety, these conditions occur about 2 times more often for people with arthritis compared to the general population. And what I hope we can all take away from today's webinar is that mental health is just as important as physical health in the management of arthritis. I hope we can also understand that health is comprised of many dimensions. The World Health Organization states that health is a state of complete physical, mental, and social well-being, and not merely the absence of a disease. And other models of health include other dimensions such as intellectual, spiritual, occupational, and environmental aspects of a person's life. So together, all of these dimensions of health are interconnected and influence our overall well-being and quality of life. I find it's helpful to distinguish between mental health and mental health disorders, especially because these terms are often used interchangeably and they are two distinct concepts that overlap. So we can think of mental health as being on a spectrum. It embodies a person's overall state of mind, a person's emotional, psychological, and social well-being. On the other hand, mental health disorders are diagnosed conditions. They are beyond a change in emotions or mood arising to ordinary events. Mental health disorders represent prolonged and excessive negative feelings that interfere with daily functioning and cause persistent distress. The most common mental health disorders are depression and anxiety. So in bringing these terms together, we can understand that everyone has mental health, but not everyone has a mental health disorder. And these two concepts are interconnected and can change over time for a person. And so this diagram here on the right shows how these two concepts interact and can basically form four quadrants. So for example, in the upper right quadrant, it illustrates that you can have positive mental health even when you have a mental health disorder. To further our understanding of mental health, what it includes are emotional responses, our sense of well-being, and our resilience. And resilience is critical to mental health. It's the ability to adapt and recover in times of stress and adversity. And it doesn't mean you go through life avoiding challenges, but instead you're developing tools to cope and navigate these challenges effectively. And as you can imagine, our mental health also influences our capacity to cope with daily stressors, develop meaningful social connections, and to overcome obstacles in life. We all encounter challenges to mental health in our life, but in the context of arthritis, which is often considered an invisible illness, individuals can experience feelings of isolation and frustration, as others may not recognize the pain and limitations it causes for a person. This lack of visible symptoms often results in misunderstood experiences, making it harder for people to receive empathy and support. On top of that, people with arthritis are faced with having to adjust to an illness. And this involves the ability to accept the diagnosis, cope with the symptoms, engage with sources of support, and readjust one's expectations of control over the disease. And as you can imagine, certain coping mechanisms might not be available for people with arthritis that they once relied on. So for example, if you really love to exercise, but you're not able to do these things anymore, that can take away some of the positive coping mechanisms that you've had in your life. So overall, challenges in adjusting can negatively affect mental health, and as you can imagine, could perhaps lead to a mental health disorder. So I want to share some research that myself and co-authors, including a patient partner, did. We decided to explore mental health in the context of arthritis by analyzing relevant Reddit threads, which is an online discussion forum. And we analyzed this in rheumatoid arthritis, or RA for short, and it looked at any discussions that covered the topic of mental health to get an idea of what people were thinking and what they were dealing with respect to their mental health. And so this study was done in RA, but it's likely that findings could also extend to experiences for people with other types of arthritis. Our findings from reading through these Reddit threads and using research techniques to summarize meaning from these discussions included that certain experiences of RA, specifically the symptoms like pain and fatigue, and then aspects of managing the disease, such as trialing medications and trying to find different resources for their health. Those aspects all had a negative impact on mental health. People also described experiencing a lack of understanding regarding their rheumatoid arthritis, which stressed their relationships and created a sense of loneliness. We also found in this work that individuals with rheumatoid arthritis felt a sense of loss, which can be an ongoing process given the chronic nature and unpredictability of the disease. The sense of loss included dimensions of daily functioning, impact on occupation, family planning, and parenting. Our results also suggested that symptoms of rheumatoid arthritis and the fact that it presents as an invisible illness can lead to a range of continuous losses and strains on relationships, especially when there's a perceived lack of understanding, which all had substantial implications for their mental health. So overall results made it clear that it's necessary to understand mental health needs of people living with arthritis and move towards better integration of mental health support in the clinical setting. So now that we've explored how arthritis affects mental health in general, I'd like to shift our focus to the connection between arthritis and mental health disorders. And I'll be focusing on depression, given that's where most of the research has been done. And when we talk about prevalence of depression, we mean how many people are living with depression, and we can report this as a percentage. So in the general population, it's estimated that about 10% of people are experiencing depression. When we specifically look at people living with different forms of arthritis, these estimates increase. For example, in ankylosing spondylitis, it's estimated that 29% experience depression, up to 39% in rheumatoid arthritis, about 17% in psoriatic arthritis, and up to 35% for people with lupus. And the prevalence of anxiety disorders, which are among the most common type of mental health disorder, is also increased for people living with arthritis. And so this relationship between arthritis and mental health disorders is very complex. There's evidence that suggests a bidirectional relationship between arthritis and depression and anxiety. And so what I mean by that is there's research to show that arthritis can lead to depression and anxiety, and then we can see the opposite. There's research to suggest that depression and anxiety can also then lead to arthritis. There's also a complex relationship among chronic pain, fatigue, arthritis, and mental health disorders, as you can see here by all the arrows going in different directions connecting them. There are lots of factors not shown here in this diagram that are all connected, but I'm showing the factors with the most research. And essentially the evidence shows that pain, fatigue, and also insomnia are predictors of depression. And so given this complex relationship between arthritis and mental health disorders, we decided to ask the question, well, what came first? And to do that, we used data that captures all healthcare visits for almost everyone in British Columbia. And what we wanted to do was describe the patterns of depression and anxiety healthcare use before and after the diagnosis of arthritis, and then compare that to people in the general population. So shown here in this graph are the percentage of people with arthritis and among the general population who had at least one visit to their physician for depression or anxiety. So that means that they went to go see their doctor with symptoms of depression and anxiety, and their doctor recognized this and recorded it in their notes. So depression is shown with a blue line and anxiety with red. And the dashed lines refer to corresponding controls from the general population. And then highlighted here in yellow is the first year of diagnosis for somebody with arthritis. And as you can see, people with arthritis were consistently more likely to visit a doctor with concerns for depression or anxiety in the 5 years before and the 5 years after their diagnosis of arthritis. And this was especially noticeable for depression. Similar findings were observed for medications used to treat depression and anxiety. Antidepressants are shown in blue and anxiolytics are shown in red. Controls representing the general population are those dashed lines. And then again in yellow here, this is the year that people received a diagnosis for their arthritis. And overall, the use of antidepressants and anxiolytics was much higher for people with arthritis in the years before a diagnosis of arthritis, and this continued long after a diagnosis of arthritis. So you might be wondering, what do these research findings mean? Really, we don't have a single answer, but we have a few ideas. First, there's some symptom overlap between arthritis and mental health disorders like depression. So symptoms like fatigue and pain overlap between arthritis and mental health disorders, which may lead to misdiagnoses, causing delays in identifying the underlying arthritis. Second, it often takes a long time for people with arthritis to receive a proper diagnosis. Long wait times for arthritis diagnosis could contribute to psychological distress, suggesting that timely recognition of arthritis could improve both physical and mental health outcomes. And third, there's evidence for a biological link between certain types of arthritis and mental health disorders, particularly a role of inflammation, which may increase the risk of both depression and arthritis. And if you'd like to hear more details about this study, I did an accompanying podcast with ACR Journals on Air, which is available online. And the last topic I wanted to discuss today is how gender can play a significant role in shaping how symptoms are experienced and how likely someone is to seek help for a mental health disorder. So we know that the prevalence of depression is about 2 times higher in women compared to men. However, men have an increased tendency for violent behavior, substance use, and a 3 to 4 times higher rate of suicide. And this raises an important question, which is, are men truly less likely to experience depression? Is this 2 times higher rate in women versus men real? Or are there delays in diagnosis among men that contribute to these differences? So, research that has taken a closer look at how gender influences mental health and mental health disorders suggests that there's variation in terms of the presentation or symptoms of mental health disorders, with evidence largely focused on depression. And this is a difference that I'm going to describe a bit further. There's also differences in help-seeking behaviors, with men being less likely to seek help. And then also differences in terms of treatment preference and engagement with care. Regarding how symptoms can differ, there's evidence for a male subtype of depression that is not captured in current diagnostic criteria or screening tools. The typical symptoms of depression that are well known and consistently used to evaluate if someone has depression can be considered internalizing symptoms. That's just another name for these ones. And so these include depressed mood, loss of interest or pleasure in daily activities, excessive worry or guilt, insomnia or hypersomnia. So hypersomnia meaning that you're sleeping more than usual, changes in weight or appetite, fatigue or loss of energy. But there's a number of researchers have shown a different symptom profile for depression, one that is more common in men. And these have been referred to as externalizing symptoms, and they include aggression, irritability, risk-taking behaviors, which are activities that are dangerous or potentially harmful, such as substance use, impulsivity, hyperactivity, and emotional suppression. And so these externalizing symptoms of depression can often mask the underlying emotional distress. Research in this area has also shown that underlying this masculine depression is an adherence to traditional masculine norms, such as stoicism, control, and strength. And adherence to these traditional masculine norms is associated with a greater likelihood of presenting with those externalizing symptoms, which may not be recognized by others, such as your family, friends, and clinicians. It can negatively impact help seeking, whereby men, in an effort to avoid emotional disclosure and vulnerability, only seek care once they really need it and the depression is severe. And then when men seek care, they not only have challenges with expressing depression, but have this internal discourse between what they're feeling and then their traditional masculine ideals. And all of these things can lead to delays in diagnosing depression and greater depression severity once it is diagnosed. So, to better understand how different patterns of depression symptoms relate to suicide risk in men, there was this study that analyzed a large nationally representative sample of Canadian men. The researchers identified 3 subtypes of symptom patterns, including asymptomatic, which means they had no symptoms of depression. There were a group of people that had mixed internalizing and externalizing symptoms. So a mix of those more traditional depression symptoms along with those externalizing symptoms. And then there was this third subtype that they considered as marked externalizing profile. So there were marked externalizing behaviors like substance use, anger, and risk-taking. And they found that men in this high-risk group were significantly more likely to have recently made a suicide plan or attempt. And this highlighted the importance for screening for both internal and externalizing symptoms of depression in men. So overall, it's really important to consider that depression can present differently in men and women, and that seeking and engaging with forms of support should be tailored to those differing needs. And I just wanted to wrap up with sharing a number of online resources and helplines and virtual chats. These are all also listed on Arthritis Research Canada's resource page. And I wanted to highlight that Movember and Heads Up Guys has resources more tailored towards men seeking support for their mental health. And that's it for my presentation today. I'm going to stop sharing my screen and return to the panel.
Thank you, Alyssa, for such a clear and compelling presentation about a topic which you've demonstrated affects so many of us who are living with arthritis. And before we we're now going to be moving into the Q&A session. And this is the opportunity for all the participants who were able to join us today to ask some questions both to yourself, Alyssa, as well as to Bableen. And it's a pleasure, Bableen. Thank you for joining us. Bableen is also a member of the Arthritis Research Canada's Arthritis Patient Advisory Board, and she's here with us to share her invaluable experience and insight into navigating life with a chronic condition. For all participants, you can click on the Q&A icon, which is on the lower right-hand side of your screen to type in your questions. Just notice that there's no chat function today, so we're really using that Q&A function to identify your questions. And you can upvote, meaning you can give a thumbs up to a question that is something that also intrigues you and you would like to hear the answer about. And while we're waiting for those questions to come in, Bableen, I was wondering if we could start with you. Hearing that presentation, what resonated with you? What stuck out to you?
Yeah, for sure. I think learning about the gender differences or gender norms and how they impact the way symptoms are presented in depression really stood out to me because I never really knew about the externalizing symptoms of depression, how they might look different in men when compared to women due to the traditional masculine norms. That was definitely an eye-opener for me, for sure.
Thank you, Bableen. And Alyssa, another thing that really stuck out for me was for some individuals, the inability to participate because of their arthritis and things that they could do before their diagnosis that helped with their mental health. Is that a common finding in the literature, and what kinds of examples do people provide?
Yeah, I mean, it definitely came up in the qualitative work that we did. So when we were analyzing those online discussions about mental health in the context of rheumatoid arthritis, and what really stuck out to me is there was a sense of loss in terms of occupation or exercise, things that it's not only the sense of loss, it was tied to like a loss of different coping mechanisms that really fill your cup and help with your mental health. So yeah, there was losses in terms of not being able to work or having to work different hours. And so I think it just kind of changed from what I read, it kind of just changed your ability to cope with stressors in your day-to-day life. Um, yeah, and I haven't done as much research on that since that qualitative work, but I think that's where we can see that qualitative work is so special because you're hearing directly from people who are living with arthritis about how it impacts their mental health.
Thank you. And I noticed we have some questions coming into the Q&A box. But before we go there, Bableen, is there anything that you would like to add to that question that Alyssa just addressed about that sense of loss and how that can affect mental health?
Yeah, can you just repeat the question exactly?
Yeah, so that fact that there can be, because of the diagnosis of arthritis and the symptoms of living with arthritis, that you may not be able to do some of the things that you could do before that helped your mental health. Do you have an experience related to that?
Yeah,
Or
definitely.
any?
Yeah, no, the sense of loss for sure. When I first got diagnosed myself, it didn't register to me right away, like what it means. But slowly, day by day, noticing how every little thing kind of changed, the way maybe I open a door or open a can or like a jar can, how it impacted my life, and taking those into consideration really impacted my mental health as well. And I did notice it was kind of like you lost a sense of your identity that you once had, or your identity almost changed, and being okay with that and allowing yourself to like grieve that loss, but kind of acknowledging a way to build strategies to combat, the changes that you're experiencing.
Such an important point. Great illustration there, Bableen, about how that can affect your sense of identity when you can't do some of the things that you could do previously. Let's go to some of the questions now that are in the Q&A. And the first question is there a correlation with aging, arthritis, and mental health? Was that a factor that came up in your work, Alyssa?
So I hadn't specifically looked at that. That's a great question. The work that I had been doing had been focusing more on rheumatoid arthritis, psoriatic arthritis. We've done some work in lupus that's not published yet, but tended to be more people who were diagnosed at a younger age. But I can see for sure that there would be a relationship because we also know that depression and anxiety is more common as people do get older. So maybe there could be an increase as you get older. Um, and as we know, arthritis, it's a chronic disease and it can kind of change over time. So I think it's just something that's forever in flux. Yeah, I don't know if anybody else knows.
Thank you. The next question actually is related to what you just stated, that your work has primarily been in inflammatory arthritis, and that what you presented today was focused on inflammatory arthritis. But are you aware, do these similar patterns exist to at least a degree in osteoarthritis for our listeners who don't have inflammatory arthritis? What pieces are still relevant for them?
Yeah, I think the pieces are definitely still relevant. I know that I don't have I didn't have the numbers, and I should have put them up, that people with osteoarthritis also do tend to um, are more likely to experience symptoms of mental health disorders like depression and anxiety. And I think there's crossover in terms of the pain, fatigue, and that relationship with our type of arthritis and mental health. So I think there are a lot of crossovers. Trying to think of some of the work that yeah, I won't dig into another work that I did, but yes, I can definitely see that there are crossovers.
Okay, so the content that you provided today is still applicable to people who have arthritis that isn't inflammatory arthritis.
That's right. Yeah.
Thank you.
I was particularly interested in the inflammatory piece because there's also the inflammation that underlies both depression and anxiety and inflammatory arthritis, but all the other pieces like the pain, fatigue, insomnia, um, loss of different coping mechanisms that might have helped with your mental health, those are all consistent sort of factors across the types of arthritis.
Thank you. I think that really helps our listeners who might not have or weren't sure if this material applied to them. Bableen, there's a question actually that related to how much training and how healthcare providers are prepared for supporting people living with arthritis who have mental health disorders. What's your experience with healthcare providers, and what are your thoughts about how they can be better prepared for supporting patients this way?
I mean, yeah, I would say rheumatologists have gotten or have become more holistic in their approach of dealing with conditions like this. But at the same time, I feel like mental health is still not talked about as much. They do ask questions about daily life, but they're more concerned, or typically they're more concerned about, are you still able to do the things you can do, what you can't do, and kind of focus on that and like your work, your hobbies, but they don't really go into the mental side of things. They don't really focus on, okay, you can't work as much as you did before. How is that impacting you mentally? How do you feel about that? Those questions aren't really asked. And I think a great way to start would be if rheumatologists aren't equipped to ask those questions, at least providing resources to the patients during their checkups that they're able to go to someone else to access the mental health resources. So I think that would be a great start.
Thank you. Lisa, do you have anything to add to that about preparation and training for healthcare professionals?
I mean, I think it would be great to start to integrate that more into care, while also recognizing that I know rheumatology clinics are very, very busy.
Yes.
But sometimes if I know some teams might have a nurse or a nurse practitioner on the team, so maybe there's ways to create like a team-based approach that can also include mental health as something that they're checking on for patients.
Or even referral, even if there's not, if it's a rheumatologist without the support of a nurse practitioner or someone like that, perhaps greater, as Bableen has mentioned, that they ask the question about mental health and then at least refer onwards. Thank you. There's a question about what kinds of so for participants who are sharing questions in the Q&A box, please recognize that if the questions are very personal about your own health, that we cannot expect Dr. Howren to respond to questions of personal health. That's if there's a personal health issue, that those have to be addressed with your healthcare professionals so that they can personalize that response to you. But there's a couple of thoughts that are shared in the Q&A box about what kinds of things could possibly trigger. I guess this is related to the section of your presentation on what came first. And examples that people have provided are things like having an unwell spouse, or grieving losses, etc. Or was there anything in the literature that you have read or have done research in yourself about what kinds of things might trigger those experiences of greater depression and anxiety, both before and after diagnosis?
Gosh, yeah. I mean, there's a lot of literature there, specifically if you're just looking at depression and anxiety and what kind of factors increase the risk. Um, but chronic pain is one. So regardless of arthritis, the idea of having chronic pain, having a history of any sort of mental health disorder or a family history of a mental health disorder, experiencing grief or loss or like very stressful events in a person's life. Um, and I believe the presence of a chronic disease, so any chronic disease is often a predictor of a mental health disorder. So it doesn't mean you're going to get one. It just means that when you have these things in your life, you're more susceptible to later having depression and anxiety. But everyone's different. Our mental health is different. Our resilience, our coping mechanisms, all those things are different. And that's kind of where we see you can kind of see where people might get depression, or if somebody had good social support and positive coping mechanisms, then they might be able to avoid um, later developing depression or anxiety.
Thank you. And someone
But
also mentioned menopause. Has that come up as a factor related to?
I can't say for certainty. My research really hasn't focused on that, but I'm sure other people have looked into that.
Hey, thank you. Boy, there are so many questions coming in, and I'm doing my best to try and keep up. And I ask for the indulgence in participants that it may take me a while as I try and read these at the same time as address the questions. And thank you, Alyssa, for raising that chronic pain can also be a precipitator of this. Um, Bableen, what are I know that you work in a clinic that where exercise is physiotherapy clinic where exercise is a big part of rehabilitation. Living with arthritis and also working in this setting, what are your thoughts about the value of exercise in managing mental health?
Yeah, so I do work as a kinesiologist in a physio clinic, which kind of means that I work with people with chronic conditions or any injuries and helping them kind of go back to their baseline or just, maintaining a good physical activity level. And from that experience with my patients, at least, I've had a few stories from them. They said, I walked in to this clinic just wanting to get in better shape, but I didn't realize the impact it would also have on my mental health. I feel more calm, and they're less stressed out in the mornings, they're less agitated. So there's definitely been stories of that, people with chronic conditions experiencing better mental health. And it's definitely a positive coping mechanism for stress to exercise. And I would say the same thing as well. So I've experienced symptoms for the last roughly 10 years. And throughout that, the years that I played in my sports and like was consistent with that, my mental health was definitely at a better um, position. And yeah, staying active, especially in nature-based, is also a really good idea as well. So going out walks in the forest nearby, it doesn't have to be anything too crazy. It doesn't have to be, lifting all these weights. Just staying active will definitely help, at least based on my experience and my patients.
Well, you took the words right out of my mouth there as a physiotherapist too, valuing exercise, but also right on target. And the next question was about the value of being in nature, forest bathing. And thank you for highlighting that as well. Alyssa, did you want to add anything to that from a research side point of view?
I don't think so. I think Bableen touched on that really well. And I think nature is healing for all of us in terms of getting out and just moving your body a little bit and appreciating all the things that you see around you can really help to like calm your mind and ground you.
Thank you. And do you want to mention, there's the next question referred to cognitive behavioral therapy. Do you have any advice for listeners about what can you share about tips and take-home messages related to cognitive behavioral therapy?
I'll share what I can. I mean, I'm a PhD. It's not like I'm not a trained therapist. I'm not a medical doctor. So but I know from my research that cognitive behavioral therapy is a first line type of therapy for people with any type of mental health disorder, especially depression and anxiety. So yeah, it's proven to be very, very effective in treating depression and anxiety. And then when you combine CBT, cognitive behavioral therapy, with medications like an antidepressant, that's also been shown to be very helpful. But I think I'll recognize that it does take a long time. It's not a quick fix in a week, right? It takes multiple weeks um, of not only therapy, but also work on yourself, which can be really, really hard.
Thank you. And I'm also noticing some comments. Judith, for example, put a comment in the Q&A explaining, she could really relate to your presentation, Alyssa. The things that resonated with her were what came first. And I think that your choice of language for that has definitely spoken to some people here today. I am looking for another question. The cost of healthcare professionals. The barriers in accessing healthcare professionals to help with this. Bableen or Alyssa, do you have any comments? I know you can't control the costs and what is available, what services are available, and whether they're free but do you have any thoughts that you can share? Maybe Bableen, your thoughts first about just access to services.
Yeah, definitely. Yeah, especially with chronic conditions, physiotherapy helps a lot, especially during flare-ups. And unfortunately, physio is not covered unless you have insurance, and it can get quite expensive. So I've personally experienced times where, there were like I think years where I didn't go to physio because I was a student, I couldn't afford it. Um, and yeah, but at the same time, I did learn like different resources online that are free, um, regarding just educating yourself on how can you manage flare-ups in other ways. Um, for me, I learned like stress was a big thing, learning how to kind of schedule better in a way that I don't stress myself out with midterms or final exams because I noticed that's when I experience flare-ups. So kind of tackling other aspects that would, kind of contribute to a flare up. So kind of focusing on that. But yeah, definitely a challenge getting physio done here. It's really expensive, especially with a chronic condition, because it usually never ends. You're going every week.
So Bableen, thank you for pointing out that there are resources online, and Alyssa, you shared some of those resources that are available for people. I know that on Arthritis Research Canada's website, under resources, there's a whole host of information available, and maybe I can ask some of the individuals who are supporting us in the background from this webinar today to maybe put a link in to where those places are on the website for resources that can be accessed. Really great question here from Anonymous. So that could be almost anyone. And their question is, are there any tools available to help people to have the conversations better with their doctors, with their healthcare providers about mental health or mental health disorders? Are you aware of any resources that can specifically help them in the framing of that conversation?
I know that they do exist, and I know some of these online resources, you can often find links to help you guide discussions with a family member, a friend, or a clinician, and I can think that that can be applicable. Um, and then there are also resources for if you're concerned about somebody, how to start that conversation with them as well. But I
So
can't, I don't
maybe,
want to.
yeah, is that something that we can maybe add to the webinar after the webinar when the recording is posted? Some of those resources?
Yeah, I'd be happy to do a deeper dive in that and share that information.
Thank you. I think there's certainly an appetite from the
Yeah.
questions here to help with this. And similarly, maybe something somebody was asking, what are the tips for dealing with depression? What are the ways to manage the depression itself? Would you like to speak to that, or would you prefer to address that in resources afterwards?
Um, I'll definitely address it in resources afterwards. And again, I'm not a medical professional by any means. And I think what I do with this work is I hope it validates people's experiences, because I think the hardest part is to recognize that you're experiencing depression or anxiety. Um, so I think recognizing it first is a great step. Um, and then the next step, when you're ready, is talking to somebody who you feel safe with and that can provide you a space to be heard, whether it's a friend, family member, or your family doctor is a great place to start. They are well equipped to help you connect with resources or explore different options for treatment. Um, and then I'll put in, like, there's the Vancouver Crisis Center. There are other ones across Canada, where it's just people who are volunteered but trained in talking to people about different times of emotional distress. And they're there as a free resource 24/7 to talk to you about what you're feeling and provide an empathetic and safe space. And then they're also very well trained in terms of connecting people with mental health resources and navigating those barriers that come with that.
Thank you. So for all of those that are joining us today or watching the recording later, and you're thinking, where can I find out this list of possible resources? There's some that are already on the website for this episode, and we will add to those with the things that Alyssa has shared with us. We'll make sure that we add to those. There is a question about how medication uh, what do we know or don't know about how medications, not medications to treat the depression, but how medications might, arthritis medications, do they have any impact on depression and anxiety? Are they associated at all?
I'd say it's unclear. I don't think there's enough evidence to say one way or another at this point. It's not something that I've looked into myself in my research at this point.
Thank you. There's a question from somebody about how to find somebody who has the expertise to help them with exercise and training. And there are two resources that I'm aware of that you might want to try for that. First of all, if you live in British Columbia, and this person is from Victoria, there is, if you Google Find a Physio, Find a Physio is provided by the Physiotherapy Association of BC, and you can type in where you're located. So that will help to filter where people near you, physical therapists near you, and you can also select their area of specialty. And there is an area of specialty for arthritis. So if you say from your Victoria, you're living in Victoria and you would like somebody with specialization in arthritis, that's one way to be able to find it. Heather, thank you for kindly sharing that 988 is very helpful. It's the suicide crisis line. So thank you, Heather, for sharing that. And Shelley has a question, Alyssa. What led you to research this correlation between mental health issues and arthritis? What stimulated that for you?
That's a great question. I have to go back several years. I think first for me, it was just a personal interest in mental health. Um, and I really wanted to take that forward in my PhD work. And I've done a lot of work in arthritis prior to that. Um, and my work before was primarily focused in gout, and we did some qualitative interviews about this model of care where the patients were being contacted by different healthcare providers. Details of that are not necessary, but what stood out to me is a lot of people just express feeling that somebody cared about them and having those conversations about how they were doing, how their medication, how they were adjusting to their medications, was that sense that somebody cared. Um, so I thought, okay, maybe there's something here in terms of mental health and arthritis. And what I did was I came up with a few ideas and brought it to the patient advisory board at Arthritis Research Canada. And that's just kind of how it grew, was talking to patient partners and seeing if this was an area of interest for them and to like shape the questions that I was going to ask. Yeah, so that's kind of how it came about. I was interested just in all the connections between the two conditions, whether it's the chronic pain, the fatigue, the underlying inflammation in some cases. Um, yeah, that's kind of where
Yeah,
it's
I'm
taken me now.
smiling because it just fills my soul that the Arthritis Patient Advisory Board helped to catalyze your work in this area and then what it has led to, all your work, and how you've kindly shared it today, that was precipitated by those discussions with the members of the Arthritis Patient Advisory Board. Way to go,
Yeah,
patient partners.
exactly.
Bableen, one additional question for you here, and that's the role that stress might play. The role that stress might play in arthritis and the role that stress might play in mental health. Um, can you speak to your experience about stress as a contributor?
Yeah, honestly, I was actually shocked about how significant stress does play in my condition at least. Um, yeah, so when I did get diagnosed, I was a full-time student plus working part-time. So I had a really heavy workload plus um meeting all the deadlines. So definitely that would stress me out. And then I would get stressed out trying to meet these deadlines, but when I would get stressed out, my symptoms would get worse. My hands, I couldn't type as much, and then when I couldn't type, then I couldn't meet my deadlines. So it was just like a vicious cycle of just getting trapped. So it definitely did play a big, big impact. Yeah, and honestly, just sitting down and taking time and just learning, okay, how do I navigate this? Like, this is what I'm experiencing. What are the things that I can and can't do? So just taking that into consideration and also being okay with that. That's also a big thing, is being okay that you can't do things, that you may not be able to write notes the day before a final exam. Like you won't be able to, depending on how your body is. So learning different strategies. So for me specifically, being in school, even though it wasn't my preferred method of studying, the days that I felt okay and fine, I would write flashcards. For the days that I know I'd flare up and I couldn't even hold a pencil, that I had something. So they're just making sure you have backups and so you're not really stuck, just learning different strategies that would help you. That helped me a lot to navigate my stress. That definitely did reduce my stress levels. And also, I think another important thing is not being scared to reach out when you need help, either, in a workplace environment or academic environment. I know it's like really scary to ask for help sometimes. You're scared of the judgment, or people might judge you in a way learning about a condition you have. But at the end of the day, you would feel better and you will be able to do the things that you would want to.
Wow, Bableen, that is so powerful and a wonderful way to wrap up today. It really speaks to me. My daughter was diagnosed with rheumatoid arthritis when she was 17. And what you've explained about, adapting your study techniques to manage your disease and work with it. It's like dancing with it. You figure out the steps to the music that you're able to be successful in managing the disease, but also, keeping your mental health as you manage the disease and still continue with your studies. I'm looking at the time. I know there are a few other questions in the Q&A. For the person, Alan, who asked about is there research in biosimilar medication? Yes, and there are actually education series like today's, a webinar, at least I think one, maybe perhaps two on the website. So Alan, please check out for the website for that information on biosimilars. But looking at the time and knowing that we also want to provide you a look at the video that was prepared for this topic, I'm going to thank, first of all, Alyssa and Bableen for kindly sharing their expertise, their lived expertise, as well as their occupational expertise in this area. We also want to thank our sponsors for their support. So AbbVie, AstraZeneca, Biocon Biologics, Celtron, Oregon, Pfizer Canada, and UCP Canada. So special thanks to our presenter and Dr. Alyssa Howren, and to Bableen Parmar, who shared her personal story in the video that you're about to see. For those of you who haven't had the opportunity to visit our website and check out the other Arthritis Research Series episodes, I encourage you to do so, because there's just a wealth of information there, and many of the things that we talked about today, actually. We will be sending you a survey, and we hope that you take a few minutes to complete it, because your feedback is super important to us as we shape future episodes. And anyone who completes the survey, so this is a little carrot here for you, by June 27th will be entered into a draw to win a $25 Amazon gift card. We're now going to play the video. It's approximately 5 minutes long. So again, thank you for joining us today, whether you're watching the recording or in person, and we look forward to future episodes with you, for you.
When living with a certain condition, there are certain things that only you may notice that other people that may not even think about.
Hi, my name is Bableen, and I live with psoriatic arthritis.
I was diagnosed in my 4th year when I was studying my bachelor's in kinesiology. I have pain in majority of my joints. This includes my ankles, knees, hips, shoulders, elbows, and hands. The way I was diagnosed and the way the doctor mentioned it after, he did say that this is going to impact you mentally, but I wasn't provided resources to navigate it. A lot of times doctors have a hard time grasping the impact it has mentally, or how draining it is to experience pain every single day for the last 10 years.
So we know that mental disorders are much more common in people with arthritis. Between 20 to 40% of people with arthritis experience a mental health disorder at some point. But then where it differs is that people with arthritis have many other factors contributing to that can affect their mental health, like chronic pain, fatigue, having to manage a disease. All of those factors can negatively impact your mental health. So I think it's helpful to differentiate between what mental health is and what a mental illness or mental disorder is. You can think of mental health as somebody's overall state of mind or mental well-being, your capacity to cope with daily stressors. It exists more of on a continuum, and it can kind of fluctuate over your lifetime. So on the other hand, we have mental disorders, which are diagnosable conditions such as depression or anxiety disorders. And these cause persistent distress for a person and can impede their daily function for a long period of time.
I think it gets tiring, always having to consider another factor while making every decision of your life, because sometimes I feel like I lose myself. The disease kind of overtakes my whole personality. I think, of course, when I first felt that way, I was very emotional and wasn't really rational about finding a solution for this. I was just really upset and just caving into those thoughts. But then I realized that the hole that I'm digging is it's not gonna help my situation. I want to have the freedom or the autonomy to choose what I want to do and what I don't want to do. And I feel like if it gets worse and worse, I'm going to have a harder time mentally dealing with the fact that, hey, there are things that you can't do.
In terms of optimizing your health overall and your well-being, we need to consider both the mental and the physical health. If you have arthritis and you have a mental health disorder like depression or anxiety, that can also affect how you respond to medications, and it also can affect your ability to reach remission in your arthritis. I think it's fair to say that perhaps in arthritis, because you're dealing with a chronic disease and you're trying to manage the medications that you need to take, the pain and everything else, there's quite a focus on the physical health, and the mental health might not be the priority. So another piece of research I did was looking at all of the people in British Columbia who had a type of inflammatory arthritis and then had depression or anxiety after they were diagnosed with arthritis. And essentially what I saw is that up to half of people with inflammatory arthritis who had newly onset depression or anxiety were not receiving adequate care for their mental health. And we considered adequate care, whether it was through antidepressants or through counseling within the publicly funded healthcare system. And then even when you're ready to get help, there are barriers in terms of financial ones, in terms of paying for counseling or therapy, because that's not funded by the Canadian healthcare system at this point in time.
So I started counseling about a month after my diagnosis because I noticed that the way I was feeling wasn't changing, that at first I thought maybe time would heal and in a few weeks I'd feel better, but that wasn't the case. And then the resource that I was provided from the university, I decided, you know what, it seems like the right choice. Talking to a counselor, I felt like I could fully talk about everything I was going through without judgment, even things that, I'd feel uncomfortable telling my parents because I don't want them to feel bad. The reason that I joined Arthritis Research Canada's Patient Advisory Board was because what I dealt with when I was diagnosed was a lot, and I just can't fathom other people also going through the same thing. Yeah, the work that Arthritis Research Canada does is important because they take in the input of patients into their research.
My main hope is that people feel that their experiences with respect to their mental health is validated. And I think it's just helpful to know how common it is for people with arthritis to experience these mental health challenges. And so I hope it just empowers people to seek help and to find the courage to move past that societal stigma, to have discussions about their mental health so that they can optimize their well-being.